Okay, so as I was telling them, if you turn in your reflective paper, I put your grade in. So you should be able to see it, but now they just informed me the most important part, you can't see your overall grade. So I'll look at that and I'll email you again like I did last time. Okay. Y'all ready? I have to record this, so I can't start talking too. Plus, I'm losing my voice. All right, so I know we did upper respiratory before, and that's online. I want to go back to that because there was something I know, and I thought about you, Gallo, because right now I'm thinking about you right now. How you were writing everything down, and I went home, and I was like, "Oh my God, what was I saying? I told them the wrong thing." I always get. I'll go to it. But real quick, let's just do the upper respiratory real quick over. I want to do over, okay, with the upper respiratory. And I'll tell you why. All right, so just like anything, any illness, any infection could cause severe complications. We already talked about this, right? Nasopharyngitis is a cold, it's a virus. No virus needs an antibiotic. I don't care what your doctor prescribed you. The guideline is, in science says an antibiotic is not going to kill a virus. So never, questions will try to trick you. If it's asking about viral pneumonia, there's not going to be an antibiotic. Antibiotic is not going to be the correct answer if it's a viral anything. And likely a culture is going to be negative if it's a viral anything. It's not going to grow bacteria on a culture if it's a virus. So cultures will be negative. Now, again, remember inflammation and how inflammation occurs with rhinitis, with sinusitis, with asthma, with whatever, it's all inflammation. So it's causing vasodilation, which is causing excessive secretions and edema. So inside the nose is going to be swelling, redness, and exudate or drainage, no matter whether it's in the nose or whether it's in the lungs, in the bronchioles. That's what's going on. It's due to those inflammatory chemical mediators. Sorry. And then we already talked about phenylephrine, pseudoephedrine. Those medications do what? How do they work? Vasoconstriction. Yes, they constrict the blood vessels locally, and they help dry up the mucus and helps, bring down the edema. If the blood vessels close up more, vasoconstriction, then it's going to help dry all that up. But what is it going to do to my blood pressure? Increase it. Vasoconstriction causes increased blood pressure. Therefore, my hypertensive patients cannot take phenylephrine, pseudoephedrine, certain cold medications, because a lot of them, the way they work is they cause vasoconstriction. So we don't want to give them a medicine that's going to cause their blood pressure to go up. And then the steroids they work similarly, but they don't cause vasoconstriction. But what steroids do is decrease inflammation, right? Decrease the release of those chemicals. And so they also put us at risk for infections and things like that, but not intranasal, more systemic. And we'll talk about that in a minute. Here, I could draw you a map to where I messed up. It was right here. Why? Because I always get Kawasaki and rheumatic fever. I get the two names mixed up. Rheumatic fever down here in the bowl is a complication of strep throat, not pharyngitis, but strep pharyngitis. So that If you wrote down something about Kawasaki's disease, cross it out, delete it, act like we never talked about it. Rheumatic fever and scarlet fever go with strep throat. Scarlet fever is the rash, the sandpaper rash. And rheumatic fever is an inflammation of the valves of the heart, rheumatic fever. Don't worry, I always listen to the things I put out there. I think back, like when you had a conversation, then you think about, why did I say that? Let me go back and tell them I was lying. I don't know what I was talking about. But yeah, it's a rare complication. But if a child is coming in, if a kid is being admitted with heart issues and it's determined to be rheumatic fever, you're gonna ask, did he recently have a strep throat, sore throat, whatever? If a kid has a sandpaper rash, one of the things, if a patient, a pediatric patient has a rash, they're gonna ask them, oh, has he had a sore throat or any other symptoms? So strep, not all pharyngitis is strep. It can be viral, but if it is strep, that needs to be treated promptly with antibiotics. Technically, it needs to be droplet precaution until 24 hours after the start of antibiotics. That is why your kid can't go to school. You cannot go to work. Nobody can go anywhere with strep throat until 24 hours after the start of antibiotics. And then what are one of the things we do to prevent us from reinfecting ourselves? That's right, throw away the toothbrush. So you need antibiotics. If you did a throat culture on a kid and it came back negative, then likely it's probably viral pharyngitis, viral. If the culture is negative, then it was caused by a virus. All right, moving right along. Just some interesting pictures of all the different pharyngitis and tonsillitis a person could have. If a patient is having frequent inflammation of the tonsils, then they're going to need, maybe a doctor will suggest a tonsillectomy. But remember, what did the tonsils do?
First help you, so you don't.
They help catch the,
So you don't choke.
not so you don't choke, so it doesn't travel down your airway. So instead of getting pneumonia and lower respiratory infections, your tonsils are like filters. They're trapping that infection so it doesn't travel any further. So doctors, you'll hear some doctors suggest tonsillectomy. You'll hear some doctors who are totally against it. It's just, either one. There's no like proper exact answer. However, the surgery itself is very complex. Patients can have complications, most seriously, hemorrhage. So whether it's a sinus surgery, whether it's getting your tonsils removed, anything up in the upper airway, if the patient is frequently swallowing after surgery, that could be a sign that they're swallowing blood. They're bleeding in the back of their throat, and so they're just constantly swallowing. They can become anemic and require blood transfusion or die. So this needs to be reported to the provider if a patient just had one of these surgeries. If I'm worried about a patient bleeding, don't give them nothing red to eat or drink. Don't confuse yourself like that. Do not give them red Jello. They need a soft diet anywhere, liquids, full liquid, whatever the doctor orders. You don't need to know that because that'll be from doctor to doctor. Usually, obviously, if I just had surgery on my throat, I'm not going to be eating Doritos. So, don't give them anything red. If you're worried about anyone vomiting blood, spitting up blood, coughing up blood, keep them away from red items so not to confuse yourself and think they're bleeding. And then here's the paratonsillar abscess I was talking about before. You see how that could be a critical emergency is occluding their airway. Here's other signs of an occluded airway. Here's a normal epiglottis right above the larynx. This is epiglottitis. When a kid has epiglottitis, we don't stick anything in their mouth. We're not checking with the tongue depressor, because one false move, you touch this and it gets any more swollen, they're not going to be able to breathe. They're going to need a trach. Their whole airway is occluded. You can't shove an ET tube in there. This is a paratonsillar abscess again. So like I say, upper respiratory infection can be serious. This is one of the causes of croup. Signs of my airway being occluded, even if a kid ate a quarter, swallowed a quarter, same signs. If someone's airway is occluded and they're choking, they're going to be unable to talk, or if they do talk, it's not like, oh, I have a sore throat. It's going to sound like I'm really trying to talk around something in my throat. Okay. They're going to be talking like this, like almost like you can tell when somebody is struggling to talk. They're not going to be able to swallow their own spit. They're going to be drooling. You say they're unable to handle their own secretions. And then stridor is the sound you're going to hear. Stridor is up in the neck, in the trachea. It's a high-pitched whistling sound. That is the sound that goes with croup. Wheezing is the same sound, but it's down in the bronchus, basically. Wheezing is a high-pitched whistling sound, but it's in the chest. Croup is a high-pitched whistling sound, and it means my airway is occluded. Not croup, I'm sorry, stridor. But croup is you hear stridor with croup. Croup is an obstruction of the airway. So what does that sound like? Just like this.
How did you describe that? You said high-pitched?
High-pitched whistling sound going through a very narrow airway. So same thing, wheezing is a high-pitched whistling sound going through the airway, but it's down in the bronchus. The trachea goes down and then it breaks off into the two bronchi, the right main bronchus and the left main bronchus. And then those go into the little branches, the bronchioles. All this is online though. Like this PowerPoint is the one I put up. So this is just showing you what's going on inside there. So that air going through there is whistling. It will be like wind going through a tunnel. You're gonna hear the same noise when wind goes through a tunnel. RSV. Yes, and they'll have a barking cough and stridor. And many different things can cause croup. Croup is the name of the syndrome. It could be epiglottitis. It could be a virus. It could be different things. But croup is the name of, they just call it croup because a million different things could cause that narrowing of the airway. Not a million, but you know what I'm saying. Different infections. It's not one specific infection that causes croup.
Silly question, but how would I differentiate croup from whooping cough?
They don't, whooping cough isn't gonna have the stridor. Whooping cough isn't gonna have the stridor. Whooping cough is more the barking, like stridor is for croup. Stridor is gonna be for airway obstruction, but you'll hear stridor, like I said, if a kid swallows a marble and their airway is partially occluded, you'll hear stridor. Pertussis is down in the lungs and the airways down in the chest. It's not up here in the upper airway. So just the barking cough for pertussis. And RSV. So RSV, I mean, for us, if you or I catch RSV, it's not going to do anything to me. But 2 years and under, it can cause serious complications. and respiratory failure. Basically, it's just like a cold virus, but it causes them to have excessive secretions. RSV, bronchiolitis, they go hand in hand, okay? That's what it causes, bronchiolitis. So they're gonna have periods of apnea maybe, they're gonna have copious secretions, a lot of coughing, sneezing, and it's just gonna be, I don't know if any of you ever had a baby with RSV, but it's excessive. They're just running like, ugh, it's just, But anyway, they're gonna be on droplet and contact
Hold
ice.
on, 1 second.
What? Oh, I forgot I was recording. I'm like, the computer was talking. All right. So yeah, so they're gonna be on isolation. Don't take anything out of the room or anything. Epiglottitis, this is just again showing you the signs and symptoms of epiglottitis. When you see this, just think croup. This is croup too, okay? What's the treatment? Cool mist. You give them a cool mist, humidified air. This is the first line treatment. Racemic epi, okay? Just like with asthma. In these situations, oxygen isn't first. Why? Because I need the airway open first. A, B, C. Airway first. Racemic epinephrine nebulized air is going to cause, what does epi do? Vasoconstriction. So it's going to cause vasoconstriction in the airway, which will bring the swelling down. It's vasodilation when the blood vessels are opening up and more blood and more chemical mediators are getting to the site of inflammation. Vasodilation is what causes swelling, redness, heat, and pain, okay? Vasodilation. So racemic epinephrine, that is a nebulizer, that would come before oxygen. And in asthma, albuterol is gonna come before oxygen. Why? Because what is the point of dumping in oxygen when my airway is like this? We need to open up the airway first so more oxygen can be delivered. So yeah, anybody who's in this right here goes for anyone with an airway occlusion, upper airway occlusion. But this is what's happening with epiglottitis and other croup syndromes. So we don't put anything in their mouth. If my patient is like this, am I going to send them to a test? No. If my patient is not stable, you don't leave that patient. That patient doesn't leave you. If your patient's in the ICU per se, and no, they're on a vent or whatever. If they're even say they're not on a vent, but they're not stable or they're on some type of medicated drip that it needs to be monitored closely, you're going to CAT scan with them if they need a test. You do not ever leave that patient or allow them to leave you or leave the floor. So that's all I'm gonna say, because now I gave away one of the review questions. So.
Wait, can you repeat that?
We'll get back to it after lunch. All right. So influenza, I'm not about to spend a whole bunch of time on influenza. You need to know it is droplet precautions. Everybody knows the flu causes muscle aches, headache, fever, malaise meaning like I'm just tired out of it. Everybody knows the signs and symptoms of the flu, I think. And it can cause severe diarrhea. All right, so droplet precautions. You need to know that. And what kind of mask do you wear for droplet? Surgical. So not the N95, and I don't know what this is. I guess this is a hybrid. This is a K95. I never heard of it till Corona season. This is not an N95 mask, okay? This is not what they look like. But the surgical mask, like what Gabby has on, that's what you wear for droplet precautions. You don't need a gown for droplet precautions, right? You don't need a gown for airborne precautions, right? All right, just contact. and neutropenic, protective. All right. Now, of course, use your common sense. If you're going in a room and you're about to get blood sprayed all over you, put a gown on. I don't care if the patient's on isolation or not. If you're about to clean up a poopy mess and it's all over the place, put a gown on if you need to. Oh, you need to know the vaccines. You need to know the difference between a live vaccine and a vaccine. Can a pregnant woman get an influenza vaccine? Yes, she can. Yes, she can. It just can't be the live version. A pregnant woman can get an influenza vaccine. The reason she can't get those other vaccines like MMR and polio and those things is because those are live too. So we can give her a flu vaccine, it just can't be live. All viruses, I mean, yes, they make some antiviral, but I don't know, I wouldn't just ride that thing out. Okay, I wouldn't recommend taking any of these medicines. But because there's a lot of side effects. Even when you go to an urgent care and you have the flu, they're gonna run down okay, so I could give you this medicine, but it could cause like I'm good. I'll just drink water and lay in my bed and watch Netflix. But anyway, supportive care. When people say supportive care, that means managing your pain, managing your fever, fluids, and rest. That is what they mean by supportive care. So if I have RSV, it's a virus, and I'm the treatment is supportive care. Giving a child bronchodilators is still part of supportive care. Giving them treating symptoms is supportive, but giving them something to cure it, like an antibiotic or an antiviral, now that's treatment, but that's not supportive care. But giving someone albuterol is still supportive care. Pneumonia, it could be viral, it could be bacterial. All right, so it just depends on what caused it. Some pneumonias need to be on isolation, some do not. Signs and symptoms could be high fever, maybe shortness of breath, crackles. You may hear crackles in the lungs. Now, if I'm listening to your lungs, you're just here for a physical, and I'm listening and I hear crackles. Am I gonna say, oh, you have pneumonia? No. What are you gonna do? Now, sometimes, write this down. Sometimes you can have crackles just, as part of the initial inspiration. So if somebody normally, because what that crackles is, it's like the popping in the alveoli. They're popping back open or whatever. Or it could be popping through secretions or mucus, right? We don't normally, when the doctor listens to your lungs, you don't normally, that's not how you breathe normally, right? So now when they're asking you to take a deep breath, initially you may hear some crackles because you're not normally using every single capacity of your lung. So initially, if you hear crackles, you got to look at your patient. If I'm just here for a sports physical, I don't have any medical problems, I feel fine, and I hear a crackle, I'm going to tell the patient to cough and just take another deep breath, cough, to kind of loosen things up, and let me listen again, because it should clear. Now, if you just hear persistent crackles, then that's fluid. So it could be a sign of pneumonia. You can hear crackles if the person has congestive heart failure or renal failure and they're overloaded with fluid. Hey, I didn't even recognize you. How's it going? She just passed the handcuffs, guys. Thank you. You're welcome. Some money in here. Carly's a great professor, so. And I heard you got a job already. I do. Yes. She just graduated last semester, guys. Just passed the board. Yeah. I'll text you later. Thank
Okay,
you.
good. Bye-bye.
Oh, all right, see? It can be done. It can be done. Matter of fact, every student I know from last semester, I haven't heard, well, I did hear of one not passing. But she'll pass, she gonna get it. But otherwise, every student I had in clinical thus far that's taken them has passed. Somebody else is taking it on Friday, so we'll see how that goes. Okay, so what was I gonna tell you? Okay, so the crackles. So like I was saying, any fluid overload. So if you have heart failure, renal failure, it doesn't matter. If you're overloaded on fluids or if you have pneumonia, you may hear crackles. Now, older adults, their body temperature tends to run lower than ours. So they may not have a fever. Any infection in older adults, confusion. Okay. Also with percussion, dullness is what you would hear over a consolidation or accumulation of fluid infection. Okay. So dullness is what you would hear on percussion. What's the normal sound you hear when percussing the lungs? Resonance. Resonance is the normal sound you hear when percussing the lungs. So when the lungs are hyperinflated, like with COPD, you're going to hear hyperresonance, okay? It's going to be like yelling into a tunnel or to a cave. Hello.
If I shallow, like nothing.
What? Probably nothing. To be honest. Okay. But back in the day, before they had chest x-ray, this is how they would diagnose pneumonia. Okay, oh, I see some dullness. I hear some crackles. The patient has pneumonia. That's how these things were diagnosed before chest x-rays and things were and then by looking at your patient, are they coughing? Are they coughing up discolored sputum? A lot of times you don't even need these tests. You can assume, well, not, you don't want to assume, but you can guess kind of what the patient has. So just remember that dullness is with pneumonia, hyperresonance, resonance is with COPD. And then pneumonia, they may have chest pain, chest wall pain, coughing, yada, yada. All right, now pneumonia can lead to ARDS, acute respiratory distress syndrome. There may be one question on the exam about this, but I want to introduce you to the concept because next semester, it will be one of your first exams. You're going to be going on to critical care stuff. I want you moving on to the next class. Like, oh, we didn't learn. I never heard of this. We never learned anything. That teacher didn't tell me anything. So whether it's infection, whether it's pneumonia, and honestly, when you're giving someone IV fluids, you cannot infuse them too rapidly. You have to be aware of the patient. If a patient is older, if a patient has already heart problems, you have to be conscious of how fast you're pushing fluids in somebody because what it can lead to is pulmonary edema. Pulmonary edema. What's happening with ARDS, this is the alveoli, and now it's filling up with fluid, infection, whatever, and it's causing fluid to basically go in the lungs. So basically the actual lung itself is swollen. The actual lung tissue itself is swollen, basically. It's filled with fluid. It's called pulmonary edema. Pulmonary edema, okay? And so what's happening, it's going to be very hard for me to breathe when the actual lung tissue went from being like this to super thick, right? The resistance that it's going to cause against me breathing now that my lungs are really swollen. So giving them oxygen doesn't help at all. Giving them oxygen alone, you can put any mask you want on them, it doesn't help. They need to be mechanically ventilated because they need the force You maybe could use a BiPAP, but usually they're gonna end up needing a mechanical ventilator because you need to push against that swollen lung tissue, if that makes sense. Also, see this patient right here? They flip them over in the prone position. The lungs are so swollen that we gotta allow gravity to work with us. So anybody who's fluid overloaded, anybody who already has lung problems, it's hard for them to breathe laying flat on their backs. And then now my lung tissue is filled with fluid. But if you lay me on my belly, it will kind of allow gravity to pull some of that pressure off and allow the ventilator to work a little better. Not only do they turn them prone, they even have a bed, an oscillating bed that's actually flipping them like a fan, like an oscillating fan goes. But the bed is doing that. It's flipping the patient around. And what is that called? When we're flipping them all around, trying to mobilize secretion. Postural drainage. That is what postural drainage is. Just letting gravity pull the secretions. You see that with cystic fibrosis. So while this exam isn't going to have, there will probably just be a basic question like the positioning of the patient, but you will be introduced to this again. So it's not something you're going to see probably on a med search for, but it's something as a nurse you want to prevent from happening, right? So no, every condition a patient has the worst possible outcome, right? So if you're treating someone, delayed treatment of sepsis, delayed treatment of infection in the lower respiratory tract like pneumonia, delayed treatment, you not being aware of signs and symptoms, not giving antibiotics when they're due can lead to this. So it's not about, oh, you're going to be working in critical care, but you do need to know you are taking care of humans and every condition has a worst possible outcome. So that's ARDS. It can also happen too with inhaling fumes. What's up?
I don't want to start right now stupid. So
No.
between this one and the pneumonia, this was just more severe. Like
This is it's called acute respiratory distress syndrome. Pneumonia is just one of the many things that could cause it. Pneumonia is just an infection in the lung, okay, in the alveoli in the lung, okay, but or in the airways. But this one could happen. You don't need an infection for it to happen. This is just it's the swelling of the lung tissue. So it's just the edema of the lung tissue causing, it's a syndrome. It's not a disease. It's syndrome. So remember, syndrome. Sepsis is a syndrome. It's not a disease. Croup is a syndrome. It's a collection of symptoms. It just goes with many causative factors could lead to that syndrome. I could have a UTI and get septic. I could have an infection in my toenail and get septic. I could have strep throat and get septic. I could have a sinus. Any infection could cause sepsis, and many different lung issues or fluid overload, rapid fluid overload especially, can cause acute respiratory distress syndrome.
On the bariatric ward, they have the beds that do that.
Yeah.
So they're so big, you can't turn them all the time. So it continually turns them for you at intervals.
That sounds so nice.
Yeah.
That sounds so
it
nice.
must be a nice hospital.
That sounds like a real, where you work at? That sounds like, oh, you guys don't have to turn big people. The bed does it for you. See, if they had that, I'd still be on the floor. I'd still be on the floor. I wouldn't have no nurse back.
It's like a conveyor belt, and you put the sheets in, and you press the button, and it pulls the patient up.
What hospital do you work at?
Cleveland Clinic.
I'm gonna make me a reservation. They do toast. Man, I'm about to tell people, I gotta call somebody. Did you hear on the bariatric floor? The bed will flip the people. All right, TB. Tuberculosis, it is an airborne infection, right? Airborne infection in the lungs. So therefore it needs airborne precautions. Now, the people who are at risk for tuberculosis are the ones who are living in crowded and confined conditions. Homeless people living in homeless shelters, people living in prisons, third world countries. You don't typically see, probably not here in Florida, but like, even like if you're from New York or if you've at least seen one Jay-Z music video, housing projects, something where people are living on top of each other like that. Not just an apartment, you know, hopefully, but on top of each other, like prison, like the PJs, okay, yes, okay. So those are gonna be your people who are at highest risk. Remember the PPD test. That is just a screening. A positive PPD test does not mean I have an active tuberculosis infection. Tuberculosis also doesn't only affect, this is a lung ridden with tuberculosis, but you see, where did I put it? I don't know where I put it, but tuberculosis destroys every organ. It's airborne, so it's going to get to the lungs first, but it has the potential to destroy every organ. It is a reportable disease. That means like HIV, like gonorrhea and chlamydia, all these diseases, COVID-19, need to be reported to the health department. You get gonorrhea and you don't get treatment and it's not reported to the health department, they will come to your house and make sure you get treated for gonorrhea.
We had a patient with TB and he went AMI, well, he left.
Oh, don't worry, they'll find you.
They did, they told him that if he does not stay and he tries to leave again, they will arrest him and take him to jail.
Yeah,
And
you messing with the CDC.
Right.
Yeah. They track everybody. They track.
COVID, they call every other day, like.
Yeah, they will come to your house. I was telling the other class, I had a coworker, she was a CNA, and she was asking me, Carla, what does it mean? The health department at my house, and her daughter was 15, and they want her to take this blue pill. I said, she probably got chlamydia or gonorrhea. And she was like, no. She said she never had sex. And I'm Marilyn Monroe, girl. I am Marilyn Monroe. Like, if the health department is coming to your house, clearly you have some communicable disease that is reportable to the health department. TB is one of those. The treatment, so it's airborne precaution. This one, you need an N95 mask. You need a negative air pressurized room. Now, there's different screening. We talk about the PPD. If a patient has ever had TB or come in contact with it, once they've had a positive PPD, it will forever be positive, even after treatment. If a patient tells you they've had a positive PPD, don't do it. I showed you the picture. The arm looks like they were burnt with acid, for God's sake. Don't do it to them if they've already told you this happened to me before. It's going to happen every time they get a PPD. So if patients had a PPD, they would do a chest x-ray or a quantiferin gold instead. The quantiferin gold is going to do the same thing though. It could be positive and just mean you have latent TB, right? Chest x-ray is going to kind of give us a better clue. Okay, we see the lesions on the lungs, but again, that's not the most accurate test. It could be lung cancer, and we mistaken it for TB on a chest x-ray. The acid-fast bacilli, a sputum culture for acid-fast bacilli is the confirmatory test for tuberculosis. There is, your book tells you about this NAAT, which is a newer form of testing, but the testing that is available globally is an acid-fast bacilli. Therefore, the CDC says this does not trump this. Everyone If you're treating them for TB, they need a positive acid-fast bacilli. The other thing about it, it requires a multi-drug treatment, and treatment lasts from 6 to 12 months, okay? Anywhere, usually about 9 months, but anywhere from 6 up to 12 months is the treatment. There are 4 drugs. The acronym is RIPE. They say they're on RIPE therapy. Rifampin, isoniazid, which is also INH. This other one, I'm not even gonna try to pronounce, and ethambutol. All of them cause hepatotoxicity. I had a patient last year who had tuberculosis. He came to the clinic coughing all in my face. He came actually like 3 times that week. Dodged a bullet, but no, he had absent breath sounds on one side. The last time he came, I was giving him antibiotics because we thought he just had pneumonia, and he had absent breath sounds. If I don't hear any air moving, that is serious. So send him to the ER. He had a pleural effusion that had taken over, like his whole lung was filled with fluid, basically the lung space. So they did the acid-fast bacilli and it was positive. And I was like, oh my God, I saw my whole life. I started reviewing my life and places I had gone and things I had done. But so what happened was they got so consumed with treating them with tuberculosis, they didn't do a thorough history. And so what happened was he ended up with ascites and end-stage liver failure because he was a drinker and he had a history of hepatitis C. You have to weigh risk versus benefit. So they had to change his therapy. He's still being treated, but I don't know what they changed him to. But yes, these drugs are very hepatotoxic. They're very harsh on the liver. Rifampin will turn all your urine and body secretions, like your sweat, orange, okay? Orangish red, whatever. What was the other thing? Oh, okay. The thing about TB. So that wasn't the first. I wasn't really scared. Why? Because I've been exposed to TB so many times. I worked in a poor neighborhood. I work with homeless people all the time. I couldn't tell you how many times job call you and say, oh, you need to come down to OC Health because this person you were because ER, we don't know what you have. You just come in, coughing in my face. I didn't know. I find out 3 days later, oh, they had tuberculosis today. Okay, awesome. That's why I know my immune system is so strong. But I did. When I moved here and got tested, my quantiferin gold test was positive. But I knew the lady, then they're like, oh my God, have you had night sweats, cough lasting more than 2 weeks? I'm sorry, I didn't even go over that part, but these are the symptoms. Cough lasting more than 2 to 3 weeks, night sweats, high fever, weight loss. Those are signs and symptoms of TB. If you work in healthcare, you ask everybody about TB when they're admitted to that facility. Okay, I'm sorry. But anyway, a patient who has a positive PPD, right? So I wanted to go back to it. So I had a positive quantiferin gold. They were trying to give me treatment. Don't give me that liver medicine. I'm trying to enjoy my weekend. I want that. I'm good. But TB, the way it works is it's going to strike also people when their immune system is compromised, okay? So people at risk for TB are going to be like your HIV patients who are immunocompromised. The reason we treat latent TB, I'm probably fine. I've probably been exposed to TB. Plenty of people have been exposed to TB, and I probably will be fine. But say in 10 years, I get breast cancer and I end up on chemotherapy. That could cause me to have an active TB infection. If a patient has an autoimmune disease and they're getting ready to start therapy, one of my other students said that her mom had rheumatoid arthritis. Part of the screening before I start you on a drug for immunosuppression is to make sure you don't have things like hepatitis B. Make sure you don't, because hepatitis B too can flare up with weakened immune system. All these opportunistic things start coming up. So if I'm going to start you on the drug to weaken your immune system, I'm going to do a PPD. I'm going to find out, do you have latent TB? We need to treat latent TB before I weaken your immune system and you end up with this active tuberculosis. Does that make sense? So people who do, even though like it doesn't matter to me right now, if I really do have latent TB and I've needed chemo or something like that, then that could be serious because now I could end up with active tuberculosis. All right, so now disorders of the pleura. This is where chest tubes come in. Anytime somebody has something going on, whether it's a hemothorax, pneumothorax, pleural effusion, they're gonna usually have like sharp, usually lateral pain or chest pain. It's gonna be on one side. It's usually not gonna be both. It's gonna cause shortness of breath. They may not be able to take a deep breath, and I'll show you why. And then maybe splinting of the chest is just, they're guarding. That's what guarding is. My stomach hurts and I'm walking around like this. That's guarding. My chest hurts. I'm walking like that. That's splinting. Same thing. All right. Effusion. The word effusion alone means liquid. You could have a pericardial or a fluid. You could have a pericardial effusion. You could have an effusion in the knee. It's a collection of fluid. Okay. So pleural effusion is a collection of fluid in the pleural space. It's not in the lung. The lungs have a pleural lining. They're in a pleural sac, right? So fluid is collecting around the lung and it's pushing in, it's decreasing the capacity of my lung. It's not allowing enough space for my lung to fully expand. Things that'll cause pleural effusions is not always infection. Pneumonia could cause it, but it could also be just fluid overload. People can just, especially when you look at, not that you're going to be reading an x-ray, but when it says bilateral pleural effusion, usually it's probably fluid overload. That's that third spacing, fluid collecting in the interstitial spaces, right? It's in between the tissues. It's going where it doesn't belong because there's just so much fluid, it doesn't have anywhere else to go. So this is why people with CHF are short of breath or end-stage renal disease when they're fluid overloaded and they're short of breath because fluid's collecting around the lungs, not inside the lungs. Lung cancer. On that last slide, it says something about transudate. Lung cancer, the cells are making their own liquid. That's, remember, transcellular fluid. That's what that is. Now, I'm going to show you chest tubes later, but sometimes, like a patient with lung cancer can get chronic pleural effusions, and they end up with a permanent chest tube, basically. Well, a chest tube for long-term use is called a pleurax drain. And that's what it looks like. It's still a chest tube, but it's one they actually go home with. So you working on a med surg floor or doing home care, you will come across these. The pleurax drain is just like that. It has a little drainage bandage. It just sits in the space. You don't need to write down everything about a pleurax drain. I'm just trying to show you guys, because you don't get much clinical experience, the type of things you're going to see. You're going to see all these things every day. Probably not ARDS, but you do need to know that a patient could get to ARDS if we don't take care of them the way we're supposed to. So a pleurax drain, you would just hook up that little bottle and it sucks the fluid right out. Anybody who works in home care, you're probably familiar with the pleurax drain. You see them all the time, especially with lung cancer patients. So again, transudate, that just means transcellular fluid. You don't have to write none of that down. As long as you know a pleural effusion is a collection of fluid in the pleurax or pleural cavity. It's going to be diagnosed by doing a chest x-ray or CT or whatever. If someone has a pleural effusion, someone has a pneumo, if somebody has anything collecting around the lung, what kind of lung sounds am I going to hear in that area? None. Crackles, right? Let me go back. Crackles is when it's fluid in here. In here, that's air passing through fluid. There's no lung tissue down here. There's no air going here, so you're going to hear nothing. Absent breath sound, you're going to be worried about something like the lung collapsing. Okay? Crackles still means air's moving. For example, asthma, wheezing isn't the worst sound you can hear. Wheezing is bad. But when someone is severe asthma attack, people die of asthma attacks, you know that. You don't hear anything because now that airway is so swollen, so full of fluid, air isn't moving. That's when you know this patient they need to be intubated if we don't do something right now. They're heading towards intubation. No air sounds. When I work ER, you have a patient come in severe asthma. We are happy when you get to wheezing. Because you're coming in and I'm hearing nothing and we're giving you neb after neb after neb. Finally, we hear wheezing. Okay, at least I know that airway opened up a little bit. So some air could travel. So absent breath sounds is the worst sound you can hear. Now, remember what I told you. You better do a history. Don't be calling the doctor like, yeah, Mrs. So-and-so, oh my God, I don't know what to do. He has absent breath sounds in the right lower lobe. Ma'am, his right lower lobe was removed in 1973 after a gunshot. So, know your patient, okay? Absent breath sounds, if your patient looks like they're breathing normal and nothing's going on, and they have absent breath sounds, maybe either look at your stethoscope, make sure it's working properly, talk to your patient, ask them, hey, you feel okay? Okay. Trust me, if somebody is not getting any air, there's going to be other signs besides absent breath sounds. Look at the bigger picture, always. Even with labs, oh my God, somebody has some crazy high, their potassium 7.9, and they're here for an ingrown toenail. And you're like, are you having any chest pain? You look good, you don't have any medical problems. Chances are the lab made a mistake or something went wrong in the lab. You do not take anything at face value. We are registered nurses. You have to critically think. You can never just ring the alarm off the first little assessment you do. You have to piece everything together. You're going to get bad lab results. Labs make mistakes, mix people's stuff up. As an experienced clinician, as time goes on, you'll be able to say, these are, your CNA brings you vitals. And the temperature is 95.9. You ain't take, well, how'd you take this temperature? 95.9? That's not compatible with life, okay? Oh, the blood pressure was 100 over 100. Let me document that. No, either send them back in the room to get a real blood pressure or go back in the room and check it yourself. You don't take anything in healthcare at face value. So absent breath sounds is what you're going to hear, whether it's a pneumo, pleural effusion, or a hemothorax. And I'll show you that in a second. Why don't I do? Oh, I know why I showed this. Okay, thoracentesis, because we're talking about pleural effusion. This will be, you can either get a chest tube, but if it's just a small pleural effusion, a small fluid collection, they could just go in with the needle and drain it out. Remember paracentesis with the ascites, and they go in with the needle and they just drain the fluid out of the peritoneal cavity? Same here. Now they're just putting the needle in the lung space, the pleural space, not in the lung, in that pleural space. If it goes in the lung, then you're going to end up with a pneumothorax with air coming out of the lung and into that pleural space. So pneumothorax actually is a complication of a thoracentesis. If they go in too deep and puncture the lung, then the patient could have a pneumo. So it's usually done under conscious sedation. The patient's usually awake for this, and they're sitting up, hunched over, and the doctor is usually going in their back. You don't need to know all that. You're not going to perform a thoracentesis, so don't worry about that. What you need to know is if you send your patient for thoracentesis and they come back and have sudden right side, chest pain and shortness of breath, you need to know, oh shoot, does my patient have a pneumo? That's what you need to know as a nurse. You don't need to know which intercostal space to go into to perform it. You don't need to know that. You're not gonna do it. Nobody is gonna give you the needle and say, hey, nurse, perform this thoracentesis. No, you just need to know what to monitor for. They're gonna get a chest x-ray beforehand, they're gonna get a chest x-ray afterwards. They should have improved breathing. They should feel more comfortable after getting all that fluid removed out of the spine. Those are the things you're gonna monitor for as a nurse. And then that fluid probably will get sent to the lab and you'll be looking out for results. Maybe it's getting tested for cancer, maybe it's getting tested for infection, but you don't need to know the ins and outs of how to perform a thoracentesis. Pneumothorax now, that's the one I was talking about, that's air. So instead of fluid, now this is a small pneumo, right? Normal will be the lung in the pleural space. Now air is collecting out of there and it's causing my lung to collapse. And it's going to get larger and larger until it completely collapses my lung. It can get so severe, my lung is so collapsed, but it's still filling with air here, that it's pushing my trachea over to the good side. It's called tracheal deviation, and that is called a tension pneumothorax. Tension pneumothorax. If I see that, if somebody's trachea seems like it's getting pulled over to one side, that is a critical emergency. Those are the people you see on a movie. They do a needle decompression. They're going to stick a needle right in that space as fast as possible, and that's like only on movies, okay? Likely you're going to get a chest tube, okay? But in the movies and in the book, it tells you stick a needle in there and let that air out and let the lung reinflate, okay? Things that can cause it, it can happen spontaneously, especially to a lot of, you see like young guys, especially tall, thin frame, like tall, thin basketball type frame, swimmer, tall, skinny guys are at risk for pneumo. Anything that causes violent coughing. So if you're a smoker, if you have asthma, chronic lung disease, anything that's like you're constantly violently coughing, you could blow a gasket, I guess, and pop your lung and have a spontaneous pneumo. And then trauma, like if you fall, you puncture, you break a rib or something, trauma could cause a pneumothorax too. And that's on the next screen. It's on there. All right. So, and then this is tension pneumo. Like I said, when the pressure is so high and now it's pushing the trachea over to the side. Hemothorax. Hemothorax is going to be blood in the space. So hemo is blood, pneumo is air, and effusion is liquid or fluid, sorry. Blunt force trauma or penetrating, getting stabbed in the chest, shot in the chest, impaled by God knows what. Those things are going to cause a hemothorax. Oops, all of them are going to be treated with a chest tube. If a pneumothorax is big enough, they're going to need a chest tube. Hemothorax, all of them are going to be treated with a chest tube. This is what a chest tube looks like. That's what it looks like when they're putting it in. This is how it'll be looking when the patient's sitting in the bed. And this is, you will do dressing changes for a chest tube. When the chest tube is being inserted, it's usually inserted either if you work in ER or ICU, they do it right there at the bedside. When it's inserted, they suture it in place. What's up?
Isn't there like specific places you have to go in depending? Like, is it the second intercostal space if it's air, and then the fifth if it's like blood or?
Probably so, but I don't put the chest tube in, so I
So you don't
don't
have to do
care.
that?
I don't concern myself. Stay in your lane. You're a nurse. If you try to memorize everybody else's job, you're gonna drive yourself crazy. You're gonna drive yourself crazy. Stay in your lane. Just like all them ventilator things. You don't need to know every type of ventilator. Why? I'm not a respiratory therapist. That's what they do. That's why they're here. So don't concern yourself trying to memorize everything about a ventilator. Why? Because that's what respiratory therapy does. But you can read it, I'm sure in the book, it tells you which intercostal space. I didn't memorize that. I memorize that. That is not gonna save my patient's life while I'm there at the bedside. I don't care. If it comes out, it comes out. I don't care which space it was in. So when it is put in, these are the patients use a Vaseline gauze or an occlusive dressing. It needs to be sealed tight, right? Once that chest tube is in. So up underneath here is an occlusive dressing, okay? Now I want to show you this video. This is a really, I know it's kind of long. It's like 15 minutes. I apologize, but it is a perfect video showing you chest tube setup, what it's looking like, what you should be monitoring as a nurse, what these things look like. Atrium is one of the biggest companies that makes, I've never worked anywhere that didn't use Atrium chest tube setup. So this is straight from the manufacturer and it's so perfect. So bear with me.
The Atrium Oasis Dry Suction Water Seal Chest Drainage products are designed to let you devote more time to your patients and less time monitoring equipment. The Oasis chest drain setup is fast and easy, especially with the adjustable dry suction regulator and prepackaged water seal ampule. The Oasis's collection chamber design features big, bold, easy-to-read numbers with large writing surfaces. Each collection column is clearly defined, so changes in patient fluid volumes can be easily detected and recorded. Tracking your patient's progress, such as following an air leak or simply observing changes in intrathoracic pressure, is easy with the high contrast of blue water in the water seal and air leak monitor chambers. Getting Up produces a complete family of Atrium Oasis dry suction water seal chest drains with the same familiar operating design. Each model is tailored to address a distinct patient need or clinical requirement following emergency chest trauma, thoracic, and open heart surgery. Each Oasis dry suction chest drain comes packaged sterile with quality CSR wrap. Detailed multi-language operating instructions are conveniently provided with each unit. Let's review these instructions and see how fast and easy the Oasis chest drains are to set up and use. First, remove the CSR wrapped unit from the non-sterile outer bag. Carefully open the CSR wrap using sterile technique and only enter the chest drain into the sterile field. Each unit comes equipped with a large, easy-to-grip handle that makes handoff and patient transport safe and easy. The sturdy swing-out floor stand should be open for setup convenience and for placement onto the floor. To begin, fill the water seal to the 2-centimeter line with the 45 milliliters of pre-packaged sterile water provided with each drain. Simply remove the pre-packaged sterile water ampule from the back of the drain, twist off the top of the ampule, and insert the tip of the water ampule into the suction port. Empty its entire contents by squeezing the ampule until all of the water empties into the drain and fills the water seal to the indicated fill line. Discard the ampule. Next, connect the chest drain to the patient by inserting the patient tube connector directly into the thoracic catheter. The patient is now on gravity drainage or to-water seal. To apply suction when prescribed by a physician, connect the suction source vacuum line directly to the chest drain suction port located on the top of the drain. Turn the suction source on and increase the vacuum to minus 80 millimeters of mercury or higher. A suction monitor bellows provided on the Oasis offers visual indication of sufficient operating vacuum levels for best performance. The suction monitor bellows must be expanded to the delta mark where indicated or beyond for a standard minus 20 centimeters of water or higher regulator setting. Visual expansion of the bellows across the suction window will confirm adequate suction operation. The Oasis suction regulator is preset to a minus 20 centimeters of water suction pressure level directly out of the package. Changing the regulator suction control setting is easily done by adjusting the rotary suction control dial located on the side of the drain. Simply dial down to lower the suction pressure setting and dial up to increase the suction pressure setting.
It's
When
always
changing
at
from a
20.
higher to a lower level, use the manual high negativity vent located on top of the chest drain after regulator adjustment to reduce excess vacuum down to the lower prescribed level. As with any chest drainage system, the drain must be placed below and kept below the level of the patient's chest in an upright position to maximize drainage efficiency. We recommend hanging the unit bedside using the multi-position hangers provided. The integrated flexi hangers accommodate today's newer bed designs. All
This
feature
part.
tubes and suction connections should be routinely checked to ensure proper leak-proof operation and chest tube patency. Like all Oasis models, the 3600 single collection chest drain incorporates a large writing surface with big, bold numbers and easy-to-read fluid level graduations. The first collection chamber column is graduated in small 1 milliliter increments up to 100 milliliters in brightly colored bold numbers. Then in 2 milliliter increments up to 200 milliliters. Subsequent collection chamber columns are graduated in 10 milliliter increments up to the maximum drain capacity of 2100 milliliters. Depending upon your hospital's preferred sampling technique, samples of drainage fluid can be taken directly from the patient tube by forming a temporary dependent
It
loop
seals
and
back
inserting
up.
a 20
You
gauge or
stick the
smaller
needle and
with
draw it
syringe
out.
at a shallow angle. Samples can also be taken directly from the Luer lock sampling port located on the patient tube connector. A water seal is a simple one-way valve which allows air to exit the chest and prevents air from returning to the patient under normal conditions. It is also a very useful diagnostic tool as it can show even the smallest trends of an air leak as well as changes in intrathoracic pressure. Assessing patient air leaks is easy with Gettinga's blue tint water and graduated air leak monitor. Continuous bubbling observed in the water seal confirms a persistent air leak in either the patient's thoracic cavity or possible tube connections. Intermittent bubbling with gentle float ball oscillation confirms the presence of an intermittent air leak. And no bubbling with minimal float ball oscillation at the bottom of the water seal indicates that no air leak is present. Bubbling from right to left in the air leak monitor must be present to confirm an active air leak. The Oasis graduated air leak monitor allows visual detection of air leaks from a low volume of 1 to a larger air leak volume of 5. Air bubbles passing through the graduated air leak monitor help the clinician assess air leak patterns and patient air leak trends. Changes in intrathoracic pressure can be determined by observing the level of the blue tint water and float ball in the graduated water seal column. Gettinga's blue tint water and float ball makes changes in patient pressure easy to monitor. When the system is connected to suction, patient intrathoracic pressure equals the suction control setting plus the float ball water column level. For gravity drainage applications, patient pressure equals the float ball water column level only. Each Oasis chest drain incorporates a high negativity float valve, which is located at the top of the water seal chamber. During normal or deep inspiration, the float valve allows thoracic patients to draw as much intrathoracic pressure as they may require during each respiratory cycle. However, during prolonged periods of accumulating vacuum pressure, the float valve automatically lowers high vacuum pressure down to a lower level. The unique controlled release valve design protects your patients against prolonged exposure to excessive negative pressures, which can accumulate as a result of repeated patient tube milking or stripping. To manually lower the height of the water seal column when connected to suction, temporarily depress the manual vent located on the top of the drain until the blue water column lowers to the desired level. It is not recommended to depress the manual vent when suction is not connected or not operating. When monitoring a patient's chest drainage system, it's important to periodically check the water seal's operation and
All I really wanted you to see is the air leak, the air bubbling, all that. That's the area of the chest tube you're looking at, like how of the suction.
for example,
Oh, wait, girl, get out of here. But that's the area you're gonna be looking at and monitoring to make sure that the chest tube is functioning. If by chance something crazy happened and the chest tube came, well, I mean, if this got knocked over or whatever, it came undone, you would just reconnect it. But say it got disconnected and this got ran over by another bed. I don't know what occurred that you would need to do this, but if the patient became disconnected, the way you could create negative pressure is to stick the tube in a cup of sterile water. Anything going in the lung has to be sterile, but by sticking it in that water, you're basically creating that negative pressure. And I'm not a physics teacher, so that's all I'm gonna say about that. Okay. And then like they said, if there's no titling, no bubbling going across, then there's no suction. And it could mean that the patient's lung has reinflated and it's time for the chest tube to come out. And then the air leak, like they showed you, would be continuous rapid bubbling, will be a sign of an air leak. If happens all the time, patient went crazy and ripped the chest tube out of their chest, then you would apply a sterile dressing, but you would leave one side open. So you would only take down of the gauze 3 sides to allow for venting, you know, as they breathe in and out, because that air is still in their chest and it needs to escape, or fluid, or whatever the case may be. So that's just another picture of it. And she showed you, I'm just showing you a lot of pictures because I know maybe not everybody is going to the hospital. And even if you are, if you're in the ER and they're just telling you, go get this, go do that, and you're not getting time to explore. So this is what wall suction looks like she showed you. So whether it's an NG tube, this suction, whether it's a chest tube, whatever, this is suction. Low continuous suction is usually set at 80 or what is it, minus 80 centimeters, whatever. 80 is usually low continuous suction, pretty much, or low intermittent, either one. 80 is the setting. This is how it really looks, okay? Look, when you have heavy things and secretions, look, this is how the new, nice, never been used equipment looks like. But when you're in the thick of it, it might start to look like that. Either one is fine. Either one is fine. All right, but that's suction, okay? Atelectasis. Now, atelectasis occurs because, again, if you're not expanding your chest all the way, expanding your lungs all the way, and taking those deep breaths, the alveoli can collapse and cause a gradual collapse of the lung, but not like a pneumo. It's not a critical emergency, okay? This gradually happens, and it can be gradually corrected through incentive spirometry. Mostly after surgery, being intubated, different things can cause patients to have atelectasis. That is why after surgery, we teach them to cough and deep breathe to prevent pneumonia and to prevent atelectasis. So many different things could cause atelectasis, but again, it's that absent breath sounds. If there's no lung tissue in the area, then you may hear absent breath sounds. This is incentive spirometry. That's what the device looks like. So you teach the patient to take deep breaths in with incentive spirometry, okay? Usually tell them to do it about every hour, every 1 to 2 hours, and it's about 10 reps. You don't just take one deep breath every hour. You do about 5-10 times, do it, and then do it again in an hour.
Is there such thing as too much?
I mean, I don't think you could breathe yourself into death.
I don't know.
I don't think so. That's a good question. But I don't think you physically could do it to yourself too much. However, you could put too much pressure on a ventilator, like when somebody else is ventilating you. Why? Because what's in between my lungs? My heart. The heart rests in between the lungs. So PEEP, for example, is pressure that they add in the ventilator. You don't need to know this, but that high pressure, if the lungs are expanding, well, now it's pressing, it's causing a decrease in space for my heart to contract and open up. So you could do like PEEP. If the respiratory therapist puts PEEP on the mechanical ventilator and you start seeing their blood pressure going down, they'll say, oh no, take the PEEP off because it's too much pressure. But as far as me physically making, I don't think your body would let you overinflate your lungs, but I could be wrong. Learn something new every day. All right, so cough, deep breathe. If they have a chest incision, if they have abdominal incision, ladies, if you had a C-section before, you know this, you gotta split the incision. This is not how I want you to cough every hour. But that's how you're gonna cough if your stomach just got cut open, including your abdominal wall muscles were just cut open. So you have to teach a patient to splint, and effectively, it needs to be a good, I'm not gonna cough again, it's COVID season, I wanna get put out. But you want a strong cough. They need to be clearing their airway. All right, cystic fibrosis. There was really no risk factor except for your parents carried the genes, okay? This is one of the disorders that is pretty much exclusive to Caucasians, but anything's possible, right? But it is a genetic disorder, so it's not like you're gonna teach them about smoking cessation, it's just genes, it's the genes. So you can do genetic counseling, you can do DNA testing prior to getting together and having a baby.
Isn't it the one where they like wear the vest?
Yeah, that's one of the therapies. Yep, and I'm gonna show you a picture of it. What's happening basically is this thick mucus is collecting. Like somebody asked me, well, if it's just mucus and they clear it up. No, this mucus is like cement, okay? It is thick mucus, and it gets in the airways, clogs up the airways. It also messes up the digestive tract. It clogs up the pancreas. So they end up with, going back to GI, they end up with chronic pancreatitis, basically. So complications of chronic pancreatitis, they're gonna be malnourished. They're gonna need to take that pancreolipase enzymes. They're gonna be at risk for diabetes after a while because the pancreas produces insulin. They're gonna be at risk for lung infections with all that mucus collected. And yes, because that mucus is so thick, they do need chest physiotherapy, that cupping and beating on the chest, or the vibration, the vest that does it for you. Things with, okay, the pancreas, it also causes a lot of sodium and chloride to be, that's what the secretions have. They're heavy in chloride and sodium. So the diagnostic test, write it down, diagnostic test for cystic fibrosis is the sweat chloride test, okay? That is one of the diagnostic tests outside of genetic testing. The other thing, if my pancreas isn't working, then I'm gonna have that steatorrhea, them greasy fatty stools. If my pancreas isn't working, it's not producing those pancreatic enzymes to break down fat in my diet, I'm gonna have fat in my stool because this can come right out of me. I wasn't able to break it down. They could end up with gallbladder, anything that, if you remember from the pancreas, any of those issues they can have with cystic fibrosis. And there's that vest Brittany was talking about. They need that vibration and percussion to help break up those thick mucus secretions. You'll see it done in the hospital, usually respiratory therapy. Again, this is one of their things. Parents of these kids, they do it at home all the time. So sweat chloride test is a diagnostic test. Treatment, pancreatic enzymes. They need to take those with their meals, right? And then mucolytics, acetylcysteine, what is that? Yes, that is the antidote to Tylenol, acetylcysteine. Acetylcysteine is also a mucolytic agent. It breaks down those thick, nasty secretions, okay? So they may get acetylcysteine. Gonna give them water-soluble multivitamins. Why? Because they already got an issue with fats, right? So it's gonna be not fat-soluble, but water-soluble. Anyway, postural drainage. Again, just like with the ARDS, we're using gravity to mobilize secretions. So whether it's tilting the bed a certain way or whatever, that's all that postural drainage is. Chest percussion is just that, percussion, banging on the chest. And then the vibration, they usually use a vest or something for either one of these, but I guess they could do it manually as well. So that's it with cystic fibrosis. We're almost there, people. All right, now last are the airway diseases. Airway diseases, that's asthma, bronchitis, COPD, airway, right? So going back, like I said before about rhinitis, think about inflammatory processes from week 1. What's happening in the airways is bronchodilation is occurring. It's causing more white blood cells, eosinophils especially, more white blood cells, excessive secretions. It's causing edema. That's what's going on inside of my airways with COPD, asthma, and actually cystic fibrosis, okay? Because cystic fibrosis over time leads to COPD. People with cystic fibrosis do not live long. You may end up to be honest, I've never seen a picture with cystic fibrosis. It's a rare genetic disorder, but book says, I read the book. You said what?
My friend's son has it.
Yeah. And is he doing okay?
Yeah, he's 12, and when he was born, they said he wouldn't make it to be like.
That's what I was gonna say. That you
Yeah.
may end up talking to them. It may just be palliative end of life care,
Yeah.
adolescence, like.
I do know, sometimes I like to donate eggs sometimes.
Uh-huh.
I do that at like in school, whatever. Like you have to do like a genetic screening for it.
Yeah.
And I found out that I'm a carrier for cystic fibrosis.
Ooh, so you gotta screen your man.
Oh, I already did.
I don't know if this relationship's gonna work. What are your jeans looking like? What you got in them jeans? What you got in them jeans, boy?
We've
Oh,
known each other forever, like 10 years, whatever.
oh my God, please tell me you didn't have it.
No, he doesn't.
Okay.
But I found out I had, I'm a carrier of cystic fibrosis, this weird thing called Fragile X syndrome.
Fragile X.
Yeah,
Those
I
babies
think
don't
that-
survive,
But
right?
the cystic fibrosis hit me hard because I knew it was like rare and stuff, and I was like, I'm carrying that. So
So probably one of your parents is carrying it and they passed it to you, but you just didn't happen to get the disease thing.
I thought both parents have to carry it.
Right, but to get the disease.
Oh,
So like sickle cell, usually both parents, if both parents have the trait, then the kid is probably gonna end up with sickle cell disease, same thing. So there's different ones, like if it needs both parents, but also sickle cell, if your mom has sickle cell disease, you could likely end up with sickle cell regardless of what your dad has going on.
Yeah, that was the crazy thing to me. My friend was like, "Oh, my son has cystic fibrosis." He's like, "But the crazy part is, doctors told us that he would not live to be beyond 10,
Yeah.
and they have to pay like $600 a month for that vest."
Yeah, oh gosh.
Is expensive.
Yeah, the medical care in America is expensive. So whether you have insurance or even if you're rich, some people go broke trying to stay alive. So yeah, But yeah, cystic fibrosis, you may, if you're reading, like your exams, not this necessarily exam, but proctor or whatever, and the options, one of the options may be end of life care, cystic fibrosis. They don't, so if none of the options make sense, but they're talking to parents about hospice and end of life, that's probably the answer, because usually they don't live very long. I think the oldest they live is like 40s. It's a short lifespan. All right, so airway disease, like I said, that's what the inflammation and is causing bronchospasm. You got the muscles, and I'll show you that in a second. You got the muscles contracting and spasming, causing airways to tighten up. You got increased mucus secretion, and then edema and everything going on in the airways. So here again with the bronchial smooth muscles, that's how our albuterol, our beta-2 adrenergic agonists work, right? They are relaxing the smooth muscles of the bronchi. With asthma, same thing. What I just told you is what I just told you. It's inflammation in the airways. People who are at risk, one, asthma is something that can be passed genetically. If your parents have asthma, you likely could end up with asthma. The atopic triad, like I told you about with inflammation, allergies, asthma, and eczema. All three go together. Usually people with peanut allergies, shellfish allergies, a lot of them have had asthma issues too, and vice versa. People with asthma usually have multiple allergies. It's kind of uncommon to see someone with asthma with no allergies. Those are the people who get seasonal allergies. These are all inflammatory processes, so they all go together. Asthma is reversible. Over time, it becomes irreversible, and you end up with COPD. So poorly controlled asthma, if your patient is 67 years old and still coming to the doctor for asthma attacks left and right, you don't have asthma, lady, you're 67 years old, you got COPD, okay? Which is chronic obstruction. Asthma usually is reversible obstruction of the airway. So this is a bad picture, but I was just showing you the criteria for the different types. You don't need to know this, okay? You don't need to memorize this. This comes like if you go back to school for nurse practitioner school and you need to figure out treatments, then you'll need to know the stepwise approach to asthma. So COPD, again, is going to be chronic. Now that asthma or smoking or whatever, cystic fibrosis, chronic inflammation in the airways is going to lead to chronic obstructive airway disease or chronic obstructive pulmonary disease, COPD. It's going to cause the same things, but now it's happening chronically, and that chronic inflammation is going to lead to scarring. Fibrosis is scarring, hardening. Now the lungs aren't as, elastic as they used to be. Now my airway isn't as flexible as it used to be. Chronic airway disease, chronic lung problems cause blood to back up to the right heart. It causes the right heart to work harder. So it leads to right-sided heart failure. Cor pulmonale is the name of right-sided heart failure caused by lung disease. Just think cor is like coronary artery disease, cor, pulmonale, pulmonary, those are your lungs, pulm means lungs. So cor pulmonale. I mean, COPD having is going to put you at risk for respiratory infections and all that. So like I said, this is what's going on. Chronic inflammation leads to scar tissue and damage, leads to decreased elasticity and chronic narrowing of the airways. And these people are going to have chronic hypoxia and right-sided heart failure. I'm not going to read this to you, but basically there's two different types of COPD. And there is the chronic bronchitis or there is emphysema. Chronic bronchitis is going to be more excessive sputum production and productive cough, versus emphysema is going to be more about destruction of the alveoli and air trapping in the chest. So they end up with that barrel chest. Another thing to know about chronic hypoxia, you see how this man is so red? And have you ever seen like them hardcore smoker, like cowboy looking guys, and they're so red? It's not sunburn. That's not the redness. They have excessive red blood cell production. There's not enough oxygen circulating. People who are chronic smokers have high CBC counts. Everything's high. Chronic inflammation causes high white blood cells. Chronic hypoxia, red blood cells carry oxygen, right? So if I don't have enough oxygen circulating, my body's job is to constantly try to compensate. So it's not enough oxygen coming around, I'm gonna make more red blood cells because maybe that will carry more oxygen, even though it doesn't. It's not anemia that's causing you to be hypoxic. Anemia will cause you to be hypoxic. If I don't have enough red blood cells, then I don't have enough oxygen circulating. So as an attempt to make up for the lack of oxygen, the body will make excessive red blood cells. It's called polycythemia vera. You don't need to know it now. We'll talk about it when we get to hematology. But I'm just trying to make everything make sense to you. All right. Barrel chest, increase in anterior-posterior diameter. Increase. And anterior means front. Posterior means back, right? Front to back. This diameter is increasing, making my chest more of a circle and less of an oval. Increased AP diameter. You see that on the question anywhere? Chronic hypoxia, I'm just showing you other things. This is clubbed fingernails. Those clubbed fingernails. That doesn't happen overnight because I didn't get any oxygen because I had pneumonia. That happens over years of chronic hypoxia, low oxygen. They end up, COPD people end up having real swole muscles in the neck. They get real strong in the neck because they're constantly working hard to breathe. So all these upper muscles up here end up really strong, but they're malnourished and skinny. People with COPD end up short of breath when they're eating, so they tend not to eat. It's either breathe or eat. I can't do both at the same time. So you teach them to use their bronchodilators before they eat. Peak flow. This is an assessment that asthmatics and COPD patients, they do at home. You do it, respiratory will do it, or you will do it at the hospital before you give them a NEB treatment. Let's see where your peak flow is before, and let's see where it is after treatment. Everybody's lungs are a different size. So there's no specified number as to what your best, your personal best. That's what they call it, your personal best. That is determined by your lung doctor. So don't be sitting here trying to do calculations, figuring out what is it. Doesn't matter. Doesn't matter. All right. The patient knows their personal best. Just like end-stage renal disease dialysis patients, they can tell you what their dry weight is in kilograms. They know how much they're supposed to weigh. Peak flow. What you need to know is this right here. You put the respiratory therapists usually do this, so don't worry. They put this up here, right? You see these, they know what the patient's personal best is. Say their personal best is like 800 or whatever. So they make a green zone, the yellow zone, and the red zone. So to get the patient to the peak flow, you exhale, take a deep breath in, and it's a fast, hard exhale. That's the peak flow. It's measuring incentive spirometry. Incentive spirometry is inspiration. A peak flow is measuring the force of your exhalation. If they score or if they blow and this little red dot goes up here in the green zone, they're good. Whatever medications you're taking, whatever you've been doing, keep doing what you're doing because you're about 80 to 100% of your personal best. You're good. If you score in here in this small yellow zone, you're probably about to have an asthma attack. You're approaching trouble. Use your bronchodilator. That means I'm 50 to 79 or 50 to 80% my personal best, and I need to use my inhaler. That's what yellow means. And red, you're in trouble. Get your nebulizer, go to the hospital. If you're in the red and you're nebulizing, you're still taking neb treatments at home and it's not working, you need to go to the emergency room. You're in trouble. 3 times when you check it. Again, you never just do, maybe they didn't take a good deep breath in before they did it. You don't just take one reading of anything. Anything abnormal, do multiple readings. But when you do a peak flow, it's 3 blows and you take the best one. So out of the 3 tries, which zone did they get in? Which was the best? So 1 in the red and 2 in the yellow, they're probably in the yellow. Or, you know what I'm saying? Take the best one. All right, so obviously smoking cessation. I mean, come on. We know that that's going to be prevention. Reducing other risk factors. You don't want to be around people if you work at a bar where they smoke inside. Probably don't want to work there. You're just exposing yourself to toxins and putting yourself at risk. How to manage exacerbations, how to take their meds, how to use supplemental oxygen, which we'll talk about in a minute. People with these chronic lung disease, they need to get a pneumonia vaccine. They need a flu vaccine every year. Pneumonia is every 5 years. Influenza is every year. And then teaching them, again, like I said, to use their inhalers before they eat and to make sure they don't get malnourished. They'll see respiratory and they'll probably see a pulmonologist, a lung doctor. Quick relief medicines. You have your SABAs, short-acting beta-2 adrenergic agonists. Albuterol is the main one. Now, what about if my patient is on albuterol and metoprolol? They could go against each other. My beta blocker with my beta adrenergic, right? You have to be mindful of your patients with hypertension. They may get put on a different medicine. So anyways, you don't need to know that for the test, but I'm just throwing that knowledge out there. All right. Short acting always comes first. If I got 4 medications, 4 inhalers to take, always take my albuterol first. Because again, just like with the oxygen, the rest of those medicines won't get delivered. They will be more effective if my airways are opened up more. So you always take the short acting beta adrenergic first. Before your friend Brittany puts the vest on his son, should give him his bronchodilator first. Everything, use your albuterol first. If I'm going to the gym to work out, you don't tell people with asthma not to work out. You want them to exercise. However, use your bronchodilator first to prevent, bronchospasm while you're working out. Anticholinergics, ipratropium. Those things dry up secretions. Side effects, if it's going to dry up secretion, then the side effect is going to be, I might have a dry mouth, dried up secretions. And then corticosteroids, same with autoimmune disease. Corticosteroids are corticosteroids. The adverse effects of corticosteroids, I'll go over in a second, are the same. Inhaled corticosteroids are different. Inhaled corticosteroids are just localized, so they're not going to cause as many adverse effects as prednisone will. But they could put you at risk for what? Yep, oral thrush or candidiasis infection could give you even fungal pneumonia. using inhaled corticosteroids. So we teach the patients to rinse their mouth afterwards. You then have long-acting beta agonists, and you have mast cell stabilizers. All you need to know about these is, well, you know about the inhale, rinse your mouth, but always, 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 my short-acting beta agonist comes first. Systemic steroids. So, because again, the midterm's gonna have autoimmune and all that on there. Whether you're taking prednisone for Crohn's disease, whether you're taking it for asthma, whether you're taking it for chronic back pain, it doesn't matter. Steroids are steroids, and they are risky drugs. So you don't just blindly, the doctor doesn't just blindly prescribe steroids. He has to consider risk versus benefit. Short term is okay. That's what we want to use them for because of the complications of taking steroids. So you'll see it for people who are having an asthma attack. I need to tell you right now, even if they gave you IV Solumedrol, steroids do not start taking effect for 8 to 24 hours. It is not an immediate acting drug. So you're not going to see, they need it when they're in an acute exacerbation, but it's not going to happen. It's going to gradually take care of the inflammation in the lungs if you give them a systemic steroid. It doesn't happen overnight. Same with inhaled steroids. It's still not happening immediately. It's not an immediate effect like albuterol. Long-term therapy can lead to adrenal gland insufficiency. Adrenal insufficiency. The adrenal glands, they secrete and make cortisol. They make cortisol. We have cortisol in our body. So corticosteroids kill the adrenal gland. If you're chronically taking corticosteroids, your adrenal glands are going to stop making cortisol. That is what's called Addison's disease. And we'll talk about that when we get to endocrine. But long-term corticosteroids put you at risk for infection, put you at risk for diabetes, elevated blood sugars, and adrenal gland insufficiency. And then, yeah, that's it. Leukotriene modifiers like montelukast, also known as Singulair. It's a medication usually used for either allergies or asthma. It's taken at bedtime, not in the morning. It's taken at bedtime, or if it's taken for exercise-induced bronchospasm, then they take it 2 hours prior to exercise. It's not an immediate acting drug. 2 hours prior to exercise or at bedtime. That's it. And they only take it once a day. So if you took it prior to exercise, don't take it again at bedtime. Other drugs, we talked about mucolytics and acetylcysteine. That's for cystic fibrosis mostly. Versus expectorants like Mucinex, guaifenesin, expectorants. They're in all the over-the-counter cough medicines, really. They cause increased cough production. They make you cough more, and they cause increased secretion of mucus so you can cough it up. That's what expectorants do. Versus antitussives suppress your cough. You have to be careful when giving antitussives because they cause central nervous system depression, even the non-opioids. So you got to also think about who do you give these to? I'm not sure I would give something that's going to cause CNS depression or put me at risk for respiratory depression if I'm already at risk for respiratory depression. So and not everyone can get cough medicine. All right, MDI, I'm not going to read this to you, but you do need to know about how to teach a patient how to administer an MDI, how to hold their breath, how to do it. You need to know that for the exam. I'm just showing you a picture. This is a spacer. Spacers are typically used with pediatric patients to help get more medication delivered. But you can use a spacer with anyone. it helps enhance the delivery of the medication. Just showing you a nebulizer, because if you like me and you just got here from the Olive Garden and you don't have asthma, you never may have seen a nebulizer before, because I know I didn't. But that's what it looks like. This is another little short video. This is a kid using accessory muscles to breathe. Remember, intercostal muscles or seeing them doing abdominal breathing, that is a sign of respiratory distress. So when I was watching this, I was like, I'm assuming they called 911 and they're like waiting for them to get there. So they're just making a video in case they have to sue somebody. Or this kid always is in respiratory distress, so they're just used to it. Because I was like, why are they filming? What's going on?
We watched a video of one lady filmed herself having a stroke.
Dedicated to science, people. Just I'm going live. But anyway, yeah. So you saw his abdominal muscles. You can watch this at home, but I was just showing you something. Oh, get me off the screen. Get me out of here. All right. Now, you're not a respiratory therapist. You don't need to sit here and memorize all these percentages and everything else. Okay. Always remember that when you go to NCLEX, the job, the whole, when you go to boards, when you go take a proctor, they don't expect you to be a critical care nurse, a pulmonologist, a surgeon, okay? You're coming out of here a basic, not calling you basic, but you are. You're coming out of here basic as hell, okay? A basic registered nurse ready to work in an acute med-surg situation. So all the critical care stuff, while if you get those questions on NCLEX, it just may mean you're at these higher functioning questions. But don't be stressed out about learning everything about working in the ICU. This is a respiratory therapist. However, the things you need to know as a nurse, for example, nasal cannula only goes up to 6 liters. Nasal cannula, just think about it, air blowing in my nose is probably going to dry my mucous membranes in my nose. So going above 3-4 liters, you probably want to apply humidification. Make little bottles that hook up between the oxygen and the nasal cannula with a little bit of water so it humidifies the air. You don't want to irritate the mucous membranes. Non-rebreather is for your high flow oxygen. Non-rebreather is 10 to 15 liters. If my patient only needs 2 liters of oxygen, they don't need a non-rebreather mask. However, if my patient is hyperventilating and they're at risk for what? Acid-base imbalance. Respiratory alkalosis. Respiratory alkalosis. If my patient's hyperventilating and they're having an anxiety attack and they're blowing off too much CO2, we may just throw the non-rebreather mask on them just so they can breathe back in some of that CO2. They're blowing off too much CO2, they need to breathe some of it back in. For my patients with COPD, that's why we use a Venturi mask, because the Venturi mask allows us to administer oxygen, but it also allows them to retain CO2 at a good level. Patients with COPD live in a state of hypercapnia. Hypercapnia, high levels of CO2. They retain CO2 all the time. That's why they're the ones who usually end up at risk for respiratory acidosis. Their body becomes adjusted to living in that state. So when we take away too much CO2 from a patient, or we administer too much oxygen to a COPD patient, it throws off their nervous system's drive to breathe. So they live in a state of hypercapnia. That's chronic. They have become used to low oxygen, high CO2. Therefore, what's usually the cutoff of O2 administration for a COPD patient? 4 liters. You could give them a maximum of 4 liters usually. Now, you give them patients on COPD end up on a vent, they get 100% oxygen. But as a nurse, me administering medication, we do not exceed 4 liters for COPD. Textbook. Don't worry about what you see. This face tent, that just might be for those patients that need either a patient that I don't want to be all restrictive, or it could be that kid who needs that cool mist humidification. They could use that face tent. All right. And then now they even make a high flow nasal cannula. All right. So again, you're just giving them oxygen because obviously the atmosphere provides 21% oxygen. Not Bill Nye the Science Guy, and this is not an environmental science class. So you don't need to know that. But if the atmosphere, the 21% that's available in the atmosphere isn't enough and they're hypoxic, then we need to apply a supplemental oxygen that delivers more than 21%. That's it. That's the science behind that. There is such thing as oxygen toxicity. Like I said, these are some of the signs and symptoms. Not really something you need to know, every little detail about, but just knowing there, you can always do too much of just about anything. Okay, ET tubes. You don't need to be concerned with how to intubate a patient because you're not going to intubate a patient as an RN. Intubation, usually the doctor or the respiratory therapist. Those are, or unless you go back to school and become a CRNA or something like that, but you're not going to intubate patients, so you don't need to know the ins and outs of how to intubate a patient. As a nurse, you just need to know, one, this is the artificial airway that we are putting in when a patient requires mechanical ventilation. When we're performing CPR, whatever the case may be, this is what it looks like. Now, I'm not going to test you on vent alarm, but when we put the ET tube in, or even when the patient has a trach, it's the same thing, an artificial trach, just put in down here now. This is short term. Patient can only have this for 10 to 14 days. If a patient's on a ventilator, like 10 days, then in the ICU, the doc's gonna have to talk to the family because they've been on this ventilator, we can't get them off. Now we need to make a hole in their throat and put a trach in. So over time, when you get, to working all the time, you'll see people at the grocery store. You'll meet people all the time who have that scar right here, like they had a trach. Likely something serious happened to that person. Either they had a serious injury that their airway was obstructed, or something happened and they ended up on a ventilator more than 2 weeks. Whatever happened in their life. When you see people that had the trach and it went away, they don't have it anymore. Unlike your lung cancer people, the people who have part of their larynx removed, they usually have the trach for life, right? Either way, whatever the case may be, there's usually a balloon cup that needs to be inflated. It's not just to keep it in place, it's more so to prevent aspiration and to prevent pathogens from traveling down to the airway. If this is all loose in there, that leaves room. It's just a very easy access to my lower airway for all types of infection and stuff. If a patient's on a ventilator and this is deflated, when you have those pressure alarms on the vent, it's just the pressure that the vent has to pump against. So if this is all loose in here, then the pressure is going to be low. Versus if I bite on the tube, if I'm agitated and I'm biting on the ET tube, the pressure that the vent has to pump against is going to be high. So it's almost just like vasoconstriction and vasodilation. That tube's in there all loose. That's probably what's causing a low alarm. High alarm is going to be either there's a kink somewhere or they're usually biting on the tube. Just giving you a heads up. Those will be on your leadership exams, okay? Pre-procedure. Now, I'm going to show you another video. Pre-procedure, see, like right now, I don't work in the hospital. I haven't worked in the hospital since 2017. But I'm imagining with COVID, Those patients, we're not waiting until they're unconscious to ventilate, to intubate. We're talking to them prior to, hey, we got you on a BiPAP, we've tried everything, and your O2 sat is still 85%. The patient's probably still awake and alert, or at least their family is there, something, or you're calling people. You're probably gonna have to talk to them about that. Not you, I mean, you're not the one that says, hey, you need to be intubated, but you may need to provide that support. These patients usually, it's not some people are emergency, but a lot of times we're doing it before we get to an emergency. Signs of respiratory failure. If a patient has a stroke and they're grunting, they're snoring, that kind of, or they're doing the chain Stokes respirations, that's a sign this patient needs to be intubated. They can't control their respirations, or they can't protect their airway. In this video I'm about to show you, the girls OD'd on drugs. I've seen patients intubated from alcohol. You're so drunk, just like I told you about Jimi Hendrix. If you can't protect your airway, we're going to intubate you. When a patient is intubated, you need to know you cannot rely 100% on technology. The building gets struck by lightning today, the generator go out and the mechanical ventilator go off. What are we gonna do? Bag them. So if a patient is on a mechanical ventilator, that bag, that ambu bag, that resuscitation bag, whatever you want to call it, it needs to stay in the room at the bedside at all times. If the patient needs to go to a test, am I wheeling the whole ventilator? No, we're bagging them. I need to disconnect, like I told you, the patient now, your patient said they need to go to MRI. MRI is gonna have their own ventilator set up down there. Your patient is coming off a ventilator. You as the nurse are rolling with your patient and you are bagging them the whole way. This is why you don't want to come straight out of school and go to ICU and have yourself stressed out like that. Start off slow and then speed it up. Okay, don't just come out of school. I mean, you can, but for me personally, my mental health is everything. It is going to be very overwhelming as a new grad to come straight out of school and go into that. Everybody thinks it's so cool, but for a lot of people, it causes burnout because you're constantly, I'm at work so freaking stressed out, I'm about to poop my pants every time I come to work. I don't want to work like that. You're going to be at work like, I can't believe I went to school for this. This is ridiculous. I can't believe, oh, do you know what they had me do today? I can't believe this. I quit. I'm going to Monroe's. I quit. All right, so real quick, I just want to show you the process. Again, you don't have to memorize all this for the test. I'm just introducing you to as much as I can introduce you to. So when you get out here, when you go back to clinical, because some people are in the ER, you may see an intubation at work or clinical. It's like work. But when you get there, now you know. This is just like a 5-minute video, nothing crazy.
Intubation is an overdose. So you got all that, the kidney, but it's not protecting our airway all that well. So what we're going to do is we're going to intubate her to protect her airway. In preparation for the intubation, what you need to do is make sure that the entire head of the bed is ready to go. And that includes the 100% non-rebreather on the patient, suction set up so that you can suction the patient, all the way up to full and should not be on intermittent. In addition, you need diaphragm set up and with air flowing through it. The pounder needs to be set up and calibrated so that we know when the tube is in. The whole idea behind the rapid sequence intubation is to be able to get the endotracheal tube in the trachea and minimize the risk of the patient either becoming hypoxic or the patient vomiting and aspirating. So she's not protecting her airway very, very well, stretching it a little bit. And the idea is the following. What we're going to do is we're going to put the endotracheal tube into her and we'll protect her airway the rest of the way, and we'll make sure we can control her respirations as well. We've got 100% non-rebreather on her, because what we want to do is we want to wash all the nitrogen out of her lungs and be able to just have oxygen in there. So that'll give us about a minute or two to put the endotracheal tube in. As soon as we push her med, she's going to lose the rest of her airway reflexes because we're going to paralyze her, as well as sedate her a little bit more. As soon as we push the medicine, it's going to put some pressure on the cytosol respiratory membrane backwards, upwards, and to the right. So backwards, upwards, regular pressure versus the mnemonic switch.
Don't write none of this down. You're not gonna intubate it.
Tracheal tube prepared. We've got a syringe or an intensity syringe. We can blow the balloon up, and we've got a laryngoscope already set up to go, and we've checked the rate on it.
Now, when a patient goes for bronchoscopy, this is a rapid intubation, but they need to be intubated for the bronchoscopy. That's how the camera gets down in there. So, the same process, they need to hyperextend the neck, and you'll see when they intubate her, but it's the same thing when they're going for bronchoscopy. Actually, he's using a laryngeal scope, to help him see as he goes down and intubates the patient. So they're injecting her with medication to paralyze all her muscles. It's not putting her to sleep. They will give you sedation too, but you're going to be cannot even blink an eye, can't do anything. Once you have given someone that medicine, you need to be ready to intubate immediately, ready to bag the patient. They're no longer able to do anything. Their muscles are all paralyzed. So you push that drug, you're gonna see when they push it, they're gonna be bagging and getting ready to intubate. Sometimes too, when you push the drug, at first people do start to flail, but then she's limp. She's gonna be limp. There's rocuronium, pancuronium. Those are neuromuscular blockers. It's a paralytic drug. And you see he's putting the cuff in, and it had that balloon, that sack on it was the balloon that he's going to inflate once he knows he's in. And now they're bagging. So that's all I was just showing you that. What?
They don't need like Diprovan and all that kind of stuff?
I mean, Diprovan is a sedative. They do need sedatives and they need paralytics. But if I paralyze you, it doesn't matter what, you're just going to be thinking, but you're not going to be able to do anything. You're still going to be paralyzed. They do both. They give you a sedative and a paralytic. And then once you're intubated, then they just keep you sedated. And you're going to be on constant sedation. So, yeah, those were them drugs Michael Jackson was taking at his house. All right. So again, I just wanted to show you because I know your first exam next semester is going to be about all of this. Okay. So you don't need to memorize the vents now, but at least you've been introduced and you don't come to nursing 3 talk about this is too much. I never heard about this. I don't understand. So now again, so that's the ET tube, but it's the same thing. A trach is just they've made a hole down here and went in that way. If a patient needs that ET tube, if they have it long term, then they need to get a trach. Weaning, whether we're weaning them off a ventilator or whether a patient comes in and they're in the hospital and they're on oxygen. Weaning, we're going to wean them off just like you wean your baby off the bottle. You're going to wean your patient. What's a patient? You're going to, right, you know what I'm talking about. You're going to wean your patient off of oxygen unless they're going home on oxygen. Patients coming in for outpatient procedures. If they came in to get a surgery and they're supposed to go home, if your O2 set is only 91%, I have to keep giving you 2 liters. That's going to be a sign you're not ready to go home. If you came in here 100% on room air, you need to leave here 100% on room air. You don't come here, get a sinus surgery and leave here 88%. Well, the sinus surgery is over. You can go home now. No. So we wean them. If you're weaning someone off vent, that's as an ICU nurse, you would be a part of that process. Don't take notes. It's okay. I'm just exposing it. You will be a part of that process. They will remove first. They still have the tube, right? But we're going to remove the vent. Let's see how this patient does breathing with the tube on their own. If they're only breathing 4 breaths per minute, put them back on the vent. They're not ready. But if, okay, we took them off the vent, they're breathing on their own. All right, cool. Let's take the tube out next. Now let's take the tube out. If they're doing okay with the tube out, and then they're gonna just be on oxygen. And then any patient, eventually, we're gonna try to wean them off of oxygen. You started on 15 liters for the first 3 days. Let's try to scale back to 10 liters. See how you do. Can you maintain your O2 set? If you do well, fine. The doctor is going to continuously try to wean you off. We want to send you back home either in the same condition you got here, if not better, if you came in sick. So this is just the trach. Again, you see that balloon here holding it in place. I sent you all an email. If you didn't receive it, you need to go to Skills 2.0 on my ATI, apply, I think it is my ATI, apply Skills 2.0. And you need to look at the airway, airway management module. There is a video that it is a very good module. And many of the questions on the test are covered in that module. It shows you chest physiotherapy. It shows you the positioning for postural drainage. It shows you the step-by-step process of trach care and suctioning. So go to Skills, not 3.0, 2.0. And in case you forgot, I'll put it on this slide here, okay? So it's in there. Now, trying to lead y'all in the right direction here. Trying to lead my horses to water so you can drink up. Now, yeah, so we already talked about this, okay? So I'm not gonna go into that. Another reason you could end up with a trach if you have severe sleep apnea. If you have severe sleep apnea, you may need a trach. So basically continuous monitoring, knowing what the signs and symptoms, like they need suction. Sometimes patients get mucus, they get mucus buildup or mucus plug. It's going to cause obstruction of the airway, just like chronic bronchitis. Secretions are secretions. So they may be short of breath, tachycardic. You may see their O2 sat go down. Those are going to be signs my patient may need to get suctioned. Listening to their breath sounds. If it sounds all wheezy and crackly, maybe they need suction. As we're suctioning out secretion. So afterwards, their O2 sat should go up. Their lung sounds should improve. It should be more clear after suctioning. Just like with the ET tube, you always keep a bag at the bedside for a patient on a vent. A patient with a trach, you know how easily that trach could come out? Anything can happen. Patients are crazy as heck. They could be a wild sleeper, lost their trach in the sleep. You always keep extra cuffs at the bedside. One, the patient's usual size, one a size smaller. What if some swelling or something occurs and you can't get the airway back in? So always keep extra supplies at the bedside. Same, you're gonna have a pulmonologist, respiratory therapist, yada, yada. I'm not gonna go through, but you need to know the steps of suction for the midterm. You need to know the order of how a suction will be performed. Last slide. We made it, people. We made it to lunch. What time is it? Oh, look at us. We're doing good today. So hopefully, Alina, you still with me, girl? You still with me? Okay, good. Hopefully, y'all are still with me because this is the last slide. All right. So finally, this up here, it could be a mask, it could be nasal, but this is a CPAP and this is a BiPAP. These are non-invasive. This is kind of doing what the ventilator is doing, applying that pressure and forcing that air into the lungs. For patients with sleep apnea, what happens is they're laying down and their airway is getting occluded, okay? Either because they have a very narrow airway, because of their obesity, just their anatomy that they were born with, whatever the case may be. Chronic obstructive sleep apnea is just that. It's obstructing periods of not breathing. Those people that are breathing at night, like my dad, sound like they're dying in their sleep. Like, you want to just stand over them like, are you okay? That's sleep apnea. If your man snores like that, he might need to go get checked out. That is sleep apnea. People who are obese, it doesn't even have to be obese. Those bodybuilders with the big, wide neck, they're at high risk. So treatment for that is wearing the CPAP at night. Diagnostic testing for that is they go to the hospital at night or go to a sleep center at night and they actually put a pulse oximeter, or if you're in the hospital, you may be a part of that testing. Because if you work night shift, they may go to sleep with continuous, this is when we're testing them for it, they may go to sleep with continuous pulse ox or different monitors. They have monitors that go around your waist and everything to see how often is that patient not breathing at night.
You can do it at home now. Too.
Yeah, you can do an at-home sleep study, plenty of different ways to test for it. But either way, it's determining, do you need this device at night? And it could either be something nasal, a nasal cannula, or it could be a mask. It's all about patient preference. They can make a mask for your nose, whatever. But it's giving that pressure. Same with BiPAP. The difference between the two, CPAP, it moves when I breathe, it goes as I breathe, versus BiPAP is a constant pressure. And that's that. So this, if the patient has pulmonary edema, something like that, if there's CHF especially, and their lung tissues are, because they end up with pulmonary edema too. Pulmonary edema isn't ARDS, but it's what's happening. ARDS is like a severe pulmonary edema. So patients who come in for CHF, when we talk about the heart next week, they may end up on the BiPAP if it's really bad. Any questions? No? All right, I think we need a break.
Yes, time for a break.
So do you want to take, you guys have mental health today?
Yeah, midterm.
So let's do, all right, you want to take early lunch and come back at 12:30 and then do midterm review. So then that way we should be done with class by like 2:30.
Yeah.
All right, sounds good. Okay, that goes for you too at home, people.